Hello everyone, and welcome to our online lecture for Psych 1101 and Psych 1010 at Lanier Technical College. My name is Michael Holman. I'm a psychology instructor here at Lanier Tech, and I will be your narrator. Please note that these lectures are intended to assist you in better understanding the material, and should not be considered a substitute for attending lecture, reading the text, or completing your assignments. With that said, let's get started talking about psychological disorders. This time around, we're going to define psychological disorders and describe their prevalence. We will describe the symptoms, types, and possible origins of schizophrenia. We will describe the symptoms and possible origins of mood disorders, describe the symptoms and possible origins of 6 types of anxiety disorders, describe symptoms and origins for somatoform disorders, do the same thing for dissociative disorders, and do the same thing for personality disorders. So true or false? In the Middle Ages, people suspected of witchcraft were drowned as a way of proving that they were possessed. This is true. People with schizophrenia may see and hear things that are not really there. This is true. Feeling elated or happy is not always a good thing. This is true. Some people have more than one personality dwelling within them, and each one may have different allergies and eyeglass prescriptions. This is also true. Some people can kill or maim others without feelings of guilt. This is true. So, what are psychological disorders? Well, they can be characterized by rare or unusual behavior, faulty perceptions or interpretations of reality, inappropriate emotional responses, self-defeating behaviors, dangerous behaviors, or socially unacceptable behaviors. A psychological disorder is a mental condition characterized by symptoms that create significant distress, impair work, school, family, relationships, or daily living, or lead to significant risk or harm. Symptoms can be cognitive, meaning thoughts, emotional, or behavioral. Some disorders will come with a form of psychosis. This means seeing things that aren't really there, having paranoid delusions, any number of things like that. You might also have hallucinations, which are also a part of psychosis, or delusions, which are beliefs not grounded in reality. In the old days, we had lots of different ways to deal with people that had psychological disorders. We might perform an exorcism on them to cast the demon out. We might cage them up like an animal, beat them, burn them, castrate them, mutilate them, transfuse them with animal's blood. We also would do trephination, which is what you see here. This is where we would take a drill and we would bore holes into the top of their skull. The thinking was that there were evil spirits inside of this person's head and they needed extra holes in order to get out. And it certainly changed how they behaved because now they had, well, holes in their head. Fortunately, modern mental health workers view psychological disorders as persistently harmful thoughts, feelings, and actions. When behavior is deviant, distressful, and dysfunctional, psychiatrists and psychologists label it as disordered. This is important. In order for behavior to be considered disordered, to be considered abnormal, it must meet the 3 Ds. So it must be deviant, meaning that it goes against the law or against social norms. It must be distressful, meaning that it causes stress in your life. And it must be dysfunctional, meaning that it messes up your ability to function in your life every day. It has to have all 3. If it only has 1 or 2, then you do not have a disorder, you're just a little weird. So remember that defining abnormality requires distress, impairment, some risk of harm, but also considers cultural and social influences. As we grow and progress as a society, we learn about new disorders that have been around since forever, but we just weren't aware of them. We also learned that what we thought was a disorder might just be a regular way of life for many people. To classify these disorders, we use the Diagnostic and Statistical Manual, known as the DSM. It includes information on medical conditions, psychosocial problems, and global assessment of functioning. There are some concerns, however, about the reliability and validity of the standards used in the DSM. One validity that the DSM is really good at is predictive validity, meaning that if it knows your symptoms and your history, it can very easily predict whether you have a diagnosis or not, or will develop one. Now, when talking about the prevalence of psychological disorders, 50% of us will experience a psychological disorder at some time. Most often, this will start in childhood or adolescence. So yes, that's right. Half of the people listening to this video are likely to experience a disorder at some time. 25% of us will experience a psychological disorder in any given year. The APA, American Psychiatric Association, rendered a diagnostic and statistical manual of mental disorders called the DSM to describe psychological disorders. The most recent edition, the DSM-5, describes roughly 400 psychological disorders compared to 60 disorders in the 1950s. We've done a lot of research, and we have learned a lot about the human condition, and that needs to go in a book somewhere, and that kind of explains why we have so many more disorders these days. It's not that we created them, it's that we gave a name to what people were doing. This is something called multi-axial classification. We actually don't use this in current versions of the DSM, but it's still very useful for teaching students to understand what all the DSM covers. So we start with Axis 1. This is a clinical syndrome. So most disorders that are in the book fall under clinical syndrome. Axis 2 is looking at personality disorders or mental retardation. So now we're talking about people that have a specific way of living. There is something within them, and it's not something that you can likely change. So that's why it's on a second axis. Axis 3, general medical conditions. So do they have a tumor? Do they have diabetes, arthritis, heart condition, anything like that? Axis 4, psychosocial or environmental problems. So this is the life axis, is what I call it. So this is anything going on in your life. Did you start a new job? Did you just get into a new relationship? Did you just end a relationship? Any number of things like that. So how are those issues affecting you? And then finally, Axis 5, the global assessment of your functioning. And you'll see this is on a scale of 0 to 100, with 100 being perfect and 0 being dead. Here are the 16 syndromes that were used in Axis 1. This is a pretty exhaustive list, but is by no means all disorders. But just to give you an idea, we have disorders usually first diagnosed in infancy, childhood, and adolescence, delirium, dementia, amnesia, and other cognitive disorders, mental disorders due to a general medical condition, substance-related disorders, schizophrenia and other psychotic disorders, mood disorders, anxiety disorders, somatoform disorders, factitious disorders, dissociative disorders, eating disorders, sexual disorders, gender identity disorder, sleep disorders, impulse control disorders not classified elsewhere, adjustment disorders, and just in case we missed one, other conditions that may be a focus of clinical attention. So that is a lot, and that is why the book is so huge now. Here is an example of a global assessment of functioning. So we have Axis 2, 3, and 4, and we've got examples for what you might look like if you were in some of these different ranges. So let's start at the top. If I said that you had a GAF score between 91 and 100, it would mean you have superior functioning in a wide range of activities. Life's problems never seem to get out of hand, and you are sought out by others because of your many positive qualities. You have no symptoms. I'm going to be honest with you. Nobody is 91 to 100. Nobody is that perfect. If you were 100, that would mean you were the Buddha. You were just perfection. Nothing bothered you. You had no issues. Life never got you down. You never got in arguments. Everything is perfect. Most people are between 70 and 80 in their scores. But let's jump down. Now you have 51 to 60. This is moderate symptoms. So you might have flat affect, meaning that your emotions don't always show like they should, occasional panic attacks, moderate difficulty in social, occupational, or school functioning. So you might have few friends, have conflict with peers or coworkers, you might be a little awkward. This probably sounds a little more familiar, which is why it's closer to what most people are dealing with. And then 1 through 10, this is at the bottom. You have persistent danger of severely hurting yourself or others through recurrent violence, for example, or persistent inability to maintain minimal personal hygiene or serious suicidal acts with clear expectation of death. If I am in my office with someone and I realize they have a GAF score between 1 and 10, we need to call a hospital. I do not need to let them out of my sight one bit, because they are not likely to stay in this world long, and they might take others with them. So the goal of the DSM is to describe the 400 plus disorders, and to determine how prevalent these disorders are. Disorders outlined by the DSM-5 are reliable, meaning that we can come to the same diagnosis each time we use the DSM. Therefore, diagnoses by different professionals are similar. This is really important, because you don't want to get diagnosed with bipolar disorder in the state of Georgia, and then you move to California and they say you've actually just got clinical depression. So, by using the same book, using the same rubric, you might say, we can all be on the same page. It is very important. Some people criticize the DSM-5 for putting any kind of behavior within the compass of psychiatry. And to that, I say, so what? We've all got issues, right? Everybody's got their own little quirks, things that make them odd. That doesn't necessarily mean that you have a disorder. It just means that you've got certain behaviors that you do that you might have in common with someone that also has a disorder. So, if anything, it can help to humanize people that have disorders with people that don't have disorders. The real difference here is that you might find yourself looking at the DSM, and if you ever find a copy, and looking through its pages and thinking, oh man, it says that if you have trouble sleeping at night, then you have this disorder. No, not at all. That's not how this works. I call that the WebMD effect, you know, where you've got this pain in your side and you look it up on WebMD and now everything you have is cancer. So that's what happens when you are not a trained professional. You know, I'm a trained professional in mental health. You are just starting out. You're just learning about this stuff for the first time. So you need to take what you read about on the internet or even in the DSM with a grain of salt, because you don't have the training or the experience to back it up. That's the difference between understanding that you might have some symptoms and getting a full-blown diagnosis. So we need to explain abnormality. Throughout the rest of this lecture, I'm going to kind of glaze over this stuff. So we're going to go over it in detail now, and then you will see a lot of the same information in the future when we get to individual disorders. So pay attention now, take good notes, and later you'll want to refer back to these notes because I'll kind of gloss over it. So we're going to start with the brain. We know that the brain can have quite an impact on abnormal behavior. Your genes might have a role to play if depression or bipolar disorder runs in your family, for example. Neurotransmitters, we know that many psychological disorders are the result of an imbalance in neurotransmitters, having too many of one or too little of another. Brain structure and function also will impact this. So the very shape of your brain or how your brain is functioning can impact whether you have a disorder as well. We also know that the person is largely responsible for a lot of abnormality. Things like classical and operant conditioning, which are hopefully familiar to you, or having maladaptive thoughts and biases, looking at the world in negative lenses, if you remember from previous lectures. The group can also have an impact. We know that social events will trigger depression, for example. This can mean the death of a loved one or losing your job. Those are social events, and they absolutely have impact on your life and your mood. All of these different factors interact together. We look at diathesis, meaning your genes, your abnormal brain structure functioning, neurotransmitter imbalances, and particular ways of thinking. So most of this was actually biological, with one thing being a cognitive or mental issue. This creates a vulnerability to having psychological disorders. So you are now vulnerable, but just because you have any or all of these, that isn't necessarily going to cause you to break down and have a psychological disorder. No, it takes combining vulnerability with stress. Stress can be physical stress, trauma, abuse, or neglect, having issues in your relationships, and even just culture-related stress. When vulnerability and stress combine together, then you are more likely to develop some sort of psychological disorder. With that said, let's focus on schizophrenia first. Schizophrenia is a severe psychological disorder characterized by disturbances in thought and language, perception and attention, motor activity, mood, and social interaction. It afflicts nearly 1% of the worldwide population, and onset occurs relatively early in life. Adverse effects of schizophrenia do tend to endure, meaning that it can stay with you for the rest of your life. In fact, it does stay with you for the rest of your life. Now, here's something that's interesting. A lot of times I've said it before, and it once again shows up here. In psychology, psychology doesn't necessarily mean good or bad. The same can be said for schizophrenic symptoms. Positive means adding something. Negative means taking something away. Remember, positive doesn't always mean good, negative doesn't always mean bad. We're saying that positive means that schizophrenia added these symptoms to your life. So these are symptoms like hallucinations, or seeing things and hearing things that aren't there. Delusion, so believing that someone is trying to kill you, or that people are talking about you, or that someone is in love with you. And looseness of association, meaning that you have trouble getting from point A to point B in any conversation. Negative symptoms are symptoms where the disease, where schizophrenia, took something away from you. They're deficiencies. So you lose your ability to express your emotions properly, or you lose motivation to do anything like pay bills or go outside. You become socially withdrawn. You don't want to be around other people, and even poverty of speech, meaning that you lose your ability to speak. So these are negative symptoms. So it's very important when understanding schizophrenia that you realize that positive and negative do not mean good and bad symptoms. They mean adding or taking something away from you. When you have mostly positive symptoms, it is more likely that you had an abrupt onset of the disorder, meaning that just one day you had a schizophrenic break and now you have schizophrenia, just out of nowhere almost. In these cases, you tend to retain your intellectual ability, so you can still be very intelligent, and you are more favorable in having a response to antipsychotic medication. So when someone has mostly positive symptoms, if we give them medication, they tend to get better. They tend to go on to live very normal and regular lives, like anybody else. But when you have mostly negative symptoms, it means that you had a gradual onset of the disorder, meaning it might have started out with losing your emotions, and then losing your ability to speak. It's very slowly throughout your life, so that by the time we get to you, you have severe intellectual impairments and you have a poor response to antipsychotic medication. So if you have mostly negative symptoms, it probably happened over a long period of time, and there's not much that we can do to help you. Medicine doesn't seem to work as well. So when schizophrenia is slow to develop, we call it chronic schizophrenia. And this kind of recovery, known as process recovery, is doubtful. Such schizophrenics usually display mostly negative symptoms. But when schizophrenia rapidly develops, we call it acute schizophrenia. And in this case, reactive recovery is better. These schizophrenics usually show mostly positive symptoms. So there are several types of schizophrenia out there. There's paranoid schizophrenia, where you have these delusions, these beliefs that people are trying to kill you, or judge you, or hurt you, or anything like that. Disorganized schizophrenia, where you are incoherent, you have extreme impairment in social situations, you cannot get from point A to point B, or anything like that. Catatonic schizophrenia, you have motor impairment, waxy flexibility, so you have issues with moving. Waxy flexibility is a very fascinating condition. You will just not move at all, almost as if you were a wax statue or a figure. And if I wanted to, I could come up to you and pose you in different positions, move your arm into the shape of an L, and you would just hold it there for hours against gravity until eventually you came out of your stupor. Mutism, meaning that you've lost the ability to speak. So that is a catatonic version of schizophrenia. So again, these are these subtypes of schizophrenia: paranoid, disorganized, and catatonic. You can also have undifferentiated, meaning that you have a combination of the top three, or you can have residual schizophrenia. This is when your symptoms have gone into withdrawal, and so that means that you're basically like everybody else. But this is only residual schizophrenia as long as you are taking your medication and maintaining treatment. If you come off of it, if you come off of your medication even a little bit, those symptoms are going to come back every single time. I have one client that he's a really nice guy, but he's a paranoid schizophrenic, and as soon as he finds himself between medication, maybe he didn't refill at the pharmacy in time or whatever it may be, he starts to have that medication run out of his system, you can see the paranoia kick in. He'll start accusing people of stealing money from him. He'll accuse his mother, whom he lives with, that she has been stealing his money, even though they share bank accounts. Any number of things like that, that she's hiding something from him. So the sad part of residual schizophrenia is that while you do get better, schizophrenia stays with you your entire life. So you do have to stay on your medication. So where does schizophrenia come from? Well, we know that there are some genetic factors. It could be a brain disorder. We know that there are risk factors such as heredity. If it runs in your family, you're more likely to get it. Complications during pregnancy and birth. And there's an odd correlation between being born during the winter months. Doesn't mean it caused it, of course, but there is a strange correlation between people born in the winter months and people with schizophrenia. We also have the dopamine theory of schizophrenia. Remember, dopamine is a neurotransmitter in your brain that is responsible for pleasure and things like that. It makes you feel good. And the idea is that having too much or too little of dopamine can lead to developing schizophrenia. But there are other perspectives, such as the socio-cultural perspective, which knows that there is a relationship between schizophrenia and lower socioeconomic status. So, remember, socioeconomic status is how broke you are, right? How much money you got? What's your financial situation? Well, it turns out the #1 population for developing schizophrenia is the homeless population. My background is working with at-risk youth and homeless teenagers and things of that nature, and I have seen this over and over and over again. Think of it this way. If you already have a genetic vulnerability, and then you find yourself homeless, you can probably agree that being homeless is quite stressful. And so because of that, it becomes very likely that you could develop a schizophrenic break. And then once you have had that schizophrenic break, it's just going to continue, because now you're not as very likely to get a job, because who's going to hire you when you're showing symptoms of being schizophrenic? So on top of being homeless, now you're schizophrenic, and your condition is keeping you homeless. And we can even take homeless people off the streets and get them, help, get them on medication, get them doing better and doing well. But the problem is that eventually they're going to have to leave our clinic, and then they're going to be back on the street. And if they're homeless, they can't afford medication, so eventually they're going to come off it, and then they're going to be right back where they started, if not worse. So that is one avenue of how this disorder can really upend people's lives. There's also the biopsychosocial perspective. So the biopsychosocial perspective is something that you're going to see a lot in this chapter, and it combines biology with your psychology, your mental situation, as well as sociology, so society at large. How those three things interact in order to develop some kind of disorder. So how they interact with schizophrenia means that you might have a genetic predisposition that also includes a genetic vulnerability, which then interacts with those other factors like how you perceive the world and any stress that you're going through in life. Biologically speaking, we know that the brain has certain hereditary issues. It can run in your family. We've talked about stress-related hormones and the dopamine hypothesis. But take a look at this one. We know that there's an interesting correlation in ventricle size. If you recall from the biology in the brain chapter, ventricles are just fluid-filled gaps in our brain that give the brain a little bit of breathing room. In someone that does not have schizophrenia, they look like this. But in someone that does have schizophrenia, they tend to look like this. They are much more enlarged. We're not sure what it means exactly, but it's something that we see consistently in many schizophrenic patients. We also need to think about the person. How do they perceive the world? Maybe they are looking at things in a very negative light, and as a result, it causes them more stress. They might have difficulty interpreting stimuli as well in less stressful ways. And of course the group, we know social selection and social causation. We've talked about that already with the homeless population. And if you've learned to have high expressed emotion thanks to your family or things like that, you tend to be a little bit more high strung, which adds more stress to your life, which adds more to the likelihood of you eventually developing this disorder. The biopsychosocial model of schizophrenia is simply saying that several biological factors, like these, combine with psychological factors like these, as well as social and sociocultural factors. All three of these combine to create a genetic vulnerability to schizophrenia, and that is when you have your schizophrenic break. Fun fact, most people have their first schizophrenic break around the age of 22. So take a moment, pause this video if you'd like, study this. These can be very useful when studying and learning about how one may develop any disorder, not just schizophrenia. All of these concepts can affect you for a multitude of psychological disorders. So I would definitely take a look at this slide for a while and take some notes if you can. Alright, moving on from schizophrenia, let's talk about mood disorders. So we're talking about emotions now. Mood disorders are characterized by disturbance in expressed emotions. There can be major depressive disorder, where you have persistent feelings of sadness, loss of interest, feelings of worthlessness or guilt, and an inability to concentrate. About 50% of those with major depressive disorder experience severe symptoms like poor appetite, weight loss, agitation, and psychomotor retardation. There's also bipolar disorder, which has mood swings from ecstatic elation, so being super happy, to deep depression. These manic behaviors include being argumentative, having a million ideas at once, and depressive behaviors could be things like lethargy, insomnia, things of that nature. Bipolar disorder is characterized by mania that often cycles with depression. It used to be called manic depression and has a lifetime prevalence about 1%. Major depressive disorder is commonly known as depression or clinical depression, and it is considered the common cold of psychological disorders. In a year, 5.8% of men and 9.5% of women report depression worldwide. That's according to the World Health Organization in 2002. But we want to talk about the difference between just being a little sad, and when you usually say, oh, I feel so depressed, versus actually having major depressive disorder. Think of being a little sad or being a little blue as like gasping for air after a hard run. Sure, you need air, but you're going to get over it pretty quickly. Having major depressive disorder is like chronic shortness of breath. You're always gasping for air. That's the difference. You're not just being sad for a little while. You're being sad for a really long time, and you can't control it. Major depressive disorder occurs when signs of depression last 2 weeks or more and are not caused by drugs or medical conditions. You might show signs of lethargy and fatigue, feelings of worthlessness, loss of interest in family and friends, or a loss of interest in activities. Another depressive disorder is known as dysthymic disorder, or dysthymia. Dysthymic disorder lies between a blue mood and major depressive disorder. It is a disorder characterized by daily depression lasting 2 years or more. So you're not just a little sad, but you're not so depressed that you can't even pay bills anymore. Instead, you just have this underlying layer of sadness that coats everything you do. I have a very good friend, and for as long as I've known her, she has suffered from dysthymic disorder, and she can have a good time, she can enjoy herself, she can enjoy her life, but there's always this level, this layer of sadness that kind of colors everything she does. And sometimes it really gets her down, so other days are not as bad. So dysthymic disorder is just having years of a layer of sadness over everything you do. Bipolar disorder used to be called manic depressive disorder. It is an alternation between depression and mania signals. Depressive symptoms include being gloomy, feeling withdrawn, inability to make decisions, tired, slowness of thought, all the things that we just talked about with depressive disorder. Manic symptoms, however, include feeling elated or super happy, euphoria, feeling really good, desire for action, being hyperactive, and having multiple ideas. You have a ton of ideas at once. So when you're depressed, you don't really want to do anything. You don't even feel like getting off the couch or getting out of bed that day. But when you're manic, you have 1,000 ideas at once, and you'll want to start your own business, to buy a new house, to buy a new car, to go out and buy a yacht, any number of things, just whatever you feel like doing. Now, one common misconception of bipolar disorder is that you will jump between moods in one day. What really happens is that you will have what we call episodes, and these can last several days to several weeks or even several months. So during this time, during an episode, you will have mostly depressive symptoms, and then you will slowly transition from depressive episode to a manic episode. And so this symptom will go away and be replaced by this one. Then this one will go away and be replaced by this one until you're fully manic. And then that will last for several days or weeks or months and what have you. So bipolar disorder is not jumping around from one emotion to the next in any given conversation. That is a different disorder which we'll talk about towards the end of this lecture. So how did these mood disorders happen? Well, once again, we're talking about the brain. We know that there are hereditary factors. We know that differences in the frontal lobe may be related, as well as issues with your amygdala. But we also want to talk about the person, the individual. And we look at Beck's negative triad. This is a very famous trap that a lot of people find themselves falling into. It's when you have a negative view of yourself, so you don't like yourself. You have a negative view of the world, so you think everything else is crap too. And you have a negative view of the future, so you think it's always going to be this way. When you hate yourself, and you hate everything else, and you think it's always going to be terrible, it's very easy to fall into the trap of depression. So that is what Beck would often warn us against, was falling into the negative triad. These are part of cognitive distortions, or looking at the world around you, taking in any information or anything that happens to you, and distorting it into a negative light, which in turn makes you feel more depressed about your situation. This also is part of an attributional style. So do you give yourself credit for things that are good in your life? Or is anything that is bad that happens in your life also your fault? So those kinds of styles can be very dangerous, of blaming yourself for everything bad that happens, even if you had no control over it. Those are unhealthy attributional styles and can often lead to depression. And of course, the group. We know that life can get you down, it can stress you out. If you just lost your job, or if you feel like you're failing a class, then you might feel a little stressed out, a little depressed. That's normal, and sometimes having a lot of life stressors can lead you to developing clinical depression. We also need to talk about social isolation. The best way to combat a mood disorder, to combat feelings of depression or mania or whatever, is to have the support of your friends. So if you're isolated, if you don't have anyone supporting you, then you don't have as many resources at your disposal. Here's just a handy graph that shows how the number of stressful life events greatly increases your risk for developing an episode of depression. So again, we've talked about biological explanations for mood disorders like genetics, such as neuroticism, which might run in your family. We know that if you are feeling helpless, if you learned helplessness, which you learned about in a previous chapter, that can also lead to a mood disorder. If you're a perfectionist or you have unrealistic expectations, it might lead you down the path of depression. We've also seen attributional styles. And from a biopsychosocial model, we know that many people are biologically predisposed, which then interacts with their self-efficacy or self-esteem and their expectations and attitudes about themselves. So it's just saying that the way you look at the world, the way you think about the world, interacts with any biological vulnerability you already have and with life stressors. Sadly, for many people suffering with depression, it hurts so much that the only way that they can conceive to get out of it, to not hurt anymore, is to attempt or to commit suicide. In any given year, about 3% of Americans will consider suicide. Suicide is the third or fourth leading cause of death for older teenagers. There are several risk factors, including feelings of depression or hopelessness, adolescent psychological problems, stressful life events like the death of a loved one or moving to a new town. Those are considered exit events. Familial experience with psychological disorders and or suicide as well. So knowing that other people have done it. Socioculturally speaking, there are several factors, including knowing it is the third leading cause of death among young people between 15 and 24. It is more common among college students than people of the same age who do not attend college, and older people are more likely to commit suicide than teenagers. 1 in 6 Native Americans has attempted suicide. African Americans are least likely to attempt suicide. 40% of the transgender population has attempted suicide. That is a massive number. 3 times as many females attempt suicide, and 4 times as many males succeed in suicide. There are several myths about suicide that I would like to address. Number 1, individuals who fail at suicide are only seeking attention. No. If someone has attempted suicide, it is because they wanted to end their lives. And now that they have failed at that, they're going to be even more depressed because they can't even kill themselves right. Discussion of suicide prompts suicide attempts. Not at all. A lot of people will say that, oh, we don't need to talk about that because what if it encourages someone to want to commit suicide? No. If you treat suicide as something to be ashamed of, that this is something shameful that you should judge others for, then you are not going to be helping anyone that is struggling with suicidal thoughts or issues. And lastly, people who would take their own lives are insane. Absolutely not. Someone willing to commit suicide is someone that is hurting so much in that moment that the pain is unbearable. They cannot conceive of the possibility that it will get better. They simply cannot see that it will happen. You can't just say, oh, lighten up, it'll get better, things will get sunny again tomorrow. No. For them, they don't think that things will get sunny anymore. They really think that this is the end, and that hurts. That emotional pain inside of them is always going to be there, and it's never going to get better. It's only going to get worse. So, they're not insane. They just want to make the pain stop. And if there's one thing that I really want you to take away from this lecture, especially when talking about suicide, is that if you ever find yourself, especially after this lecture, talking with others about suicide, or how you maybe think that it's crazy, or you might have said things in the past like, oh, that's so crazy, that's so selfish, why would you do that? Think about your loved ones, why could you do that to them? How could you leave them behind? Anything like that, right? Don't do that. Because every time you do that, you have no idea who is actually listening. You could be talking to your best friend and have no idea that maybe your best friend is struggling with suicidal thoughts. Remember, the number one way to combat depressive thoughts, which can lead to suicide, is through social support. And a lot of times, when someone does commit suicide, their loved ones will say, well, why didn't they talk to us? Why didn't they reach out? Well, maybe you said things like the examples I just gave. Maybe you let people know that you are judging people that have committed suicide or that are having these suicidal thoughts. So when you are judging people that are having these suicidal thoughts, and you're letting them know that you judge them, you're also letting your loved ones know that you are not a safe person to talk to. So if you want to be there for your friends, if they are struggling with suicidal thoughts, then you need to rethink what you say. It turns out words really do matter, that what we say has an impact on people, and that can change how they see us. So if you want to be there for your friends, if you want to be there for your family, for your loved ones, in case they are struggling with depression and with suicidal ideas, then think about what you say and how it might impact them. And that's my little soapbox. The next type of disorders we're going to talk about are anxiety disorders. So anxiety disorders have several psychological features. You're probably familiar with being anxious, worrying about things, having the fear of the worst case scenario, being nervous, not being able to relax about anything. But there are also several physical features of anxiety that you're familiar with. Things like the arousal of the sympathetic branch of the autonomic nervous system. So your palms get sweaty, you get flushed, your heart starts beating faster, you get nervous. Phobias can be specific phobias. These are irrational fears of specific objects or situations. Social phobias, which are persistent fears of scrutiny by others. And agoraphobia, fear of being in places from which it would be difficult to escape or receive help. There are countless specific phobias. If it exists, if it is a concept, then you can develop a phobia of it. You can develop a phobia of sharks, of snakes, of spiders, of heights, of social situations, of speaking in front of a class, of car doors, anything. You can develop a phobia of it. Panic disorder is when you have an abrupt attack of acute anxiety not triggered by a specific object or situation. So you have what's known as a panic attack, which has physical symptoms like shortness of breath, heavy sweating, tremors or your body shaking uncontrollably, pounding of the heart, and other symptoms that might even feel like a heart attack. But these symptoms come on for no reason. There's nothing causing you to panic in that moment. You just start panicking. Another disorder is generalized anxiety disorder. This is characterized by persistent anxiety, which cannot be attributed to an object, a situation, or an activity. Symptoms include motor tension, autonomic overarousal, and excessive vigilance. So take all the symptoms that we've already talked about of anxiety, and now imagine that you feel all of them all of the time for no reason. That is GAD. Obsessive-compulsive disorder is characterized by obsessions and compulsions. Obsessions are recurrent, anxiety-provoking thoughts or images that seem irrational and beyond your control. And compulsions are thoughts or behaviors that tend to reduce the anxiety connected with obsessions. These are irresistible urges to engage in specific acts, often repeatedly. If you've ever seen the television show Monk, which used to be on, then that person had OCD really severely. He had several obsessions. And so he might be obsessed with germs, afraid that he was going to get sick. So the only way to make himself feel better while he's obsessing over germs was to constantly wash his hands or have antibacterial wipes. So he had a compulsion of compulsive hand washing. We also see checkers. These are people that constantly have to check to make sure they didn't leave the stove on. That's the compulsion, because their obsession is that they left the stove on and they're all going to die. Or they might have the obsession with safety, and so they have to constantly make sure that their doors are locked and secured and that nobody can get in. Keeping the locks is the compulsion, but the fear of being unsafe is the obsession. There are also stress disorders, things like post-traumatic stress disorder, or PTSD, which is caused by a traumatic event, and acute stress disorder. Really, the only difference between post-traumatic stress disorder and acute stress disorder is the timing, so that's pretty important for you to remember. PTSD can occur months or years after the event and is likely to stay with the client for the rest of their lives. However, acute stress disorder will occur within a month or so of the event and will only last 2 days to 4 weeks, and then it's gone. So really, they both have very severe symptoms. We've had clients who have been so bothered by their PTSD that they will just look for a fight, and the first person to stare at them too long, they'll punch them in the face. They might start punching holes in their walls. They can be very dangerous for their loved ones, but they also can fall into severe depression and commit suicide. This is one of the major afflictions that our veterans are facing. We know that numerous veterans commit suicide as a result of PTSD every single day. So it is something that we definitely want to pay close attention to. What's interesting about anxiety is that when studying it, it doesn't have to directly affect you for it to, well, have an effect on you. There have been many cases in people developing phobias where they didn't have the traumatic event, they just saw someone else have it, but they developed the phobia as a result. So, for example, we were studying sleep around the time of September 11th, and when polled, we found that people had a far more difficult time falling asleep or just dealing with insomnia in general after the events of 9/11. So this shows that even if it doesn't affect you, it can still have an impact on you. So where do anxiety disorders come from? Well, biologically speaking, there are many genetic factors. They are highly reactive in their autonomic nervous system. And psychologically and socially speaking, We know that phobias can be conditioned fears. If you remember little Albert and his white rat, we taught him to have that mouse phobia. Cognitive bias towards focusing on threats. So you might be mentally predisposed to being a little paranoid. And of course, the biopsychosocial model. Interaction between your biology, your psychology, and social factors can in turn create an anxiety disorder. The next group of disorders we're going to talk about are somatoform disorders. These are physical problems like paralysis, pain, or persistent belief of serious disease, but there is no evidence of a physical abnormality. One type of somatoform disorder is conversion disorder. It is a major change in or loss of physical functioning, even though there's no medical reason to explain the loss of functioning. It is not intentionally done, keep in mind. So, we had one client who was in a terrible car accident that ended up with his wife's death. And he was responsible for the car accident. And afterwards, when he was released from the hospital, he still couldn't move his right arm. And we couldn't really figure out a physical reason why his arm was still paralyzed, even though it was a severe accident. And so we theorized that he needed counseling, and it turned out he subconsciously blamed himself for the loss of his wife. And because he didn't want to accept that that was what this was, that he was in some part responsible for his wife's death, his mind took it out on him physically by making him lose a part of himself, because he felt with his wife's death that he had lost a part of himself. In this case, it was his arm. Another somatoform disorder is hypochondriasis. This is the insistence that you have a serious physical illness, even though no medical evidence of illness can be found. You may seek the opinion of one doctor after another, but nobody can find anything, and you just get frustrated and more frustrated and more frustrated. There's another story of a clinician that went to a home because the family matriarch, Grandma, she had just had a birthday, but ever since her birthday party, she refused to leave her bed. And she wasn't physically ill. No one could figure out what was wrong with her. So the psychologist goes up and he talks to her, and after a few minutes, he comes back down and goes, I know what's wrong with her. And they go, well, what is it? And he says, well, who gave her a stethoscope for her birthday? She had been, ever since her birthday party, laying in bed listening to her heart, because she was certain that her heart was skipping a beat every now and then. And she just knew that it was happening, and so she refused to get out of bed because she knew that there was something wrong with her heart, and she was listening all day. She was also hiding the stethoscope so that nobody else could find it. Another somatoform disorder is body dysmorphic disorder. It is a preoccupation with a fantasized or exaggerated physical defect in your appearance. You may assume others also see you as deformed. We see this a lot with anorexic patients. They will also have body dysmorphia, but it doesn't have to be an eating disorder. There is one case of a man, they call him the human Ken doll, and he is obsessed with plastic surgery. He has had countless plastic surgeries at this point, and most recently he even showed up on the red carpet, and he was carrying a jar, and inside the jar were the ribs that he had just had removed to make himself look more perfect. He calls his body his canvas now at this point, but really he sees these imperfections in his body and he continues to alter himself. So people with body dysmorphia will see themselves as ugly even if no one else does. They'll see themselves as overweight or too skinny or anything like that. So it can appear in a number of different ways, and they will go to extreme lengths to try and change this. We've talked about eating disorders before in a previous lecture. We have things like anorexia nervosa, which does involve body image distortion, but also involves not eating and starving yourself to death, almost to death. There's also bulimia nervosa, where one binges and eats tons of food and then immediately purges. We know that there are several factors, including society, how the individual was raised, as well as group factors and biological predispositions. This is an interesting chart. When we polled patients with eating disorders, we would ask them, where do they see themselves? So they would say that they think that this is what men find attractive. They would say that this is the weight, the body size that they see themselves as, and this is how they feel when they look in the mirror. But this is how they actually look. So that's an interesting insight into the issues that many people struggling with body image distortion will go through. It's different what you perceive from what is actual reality. So let's explain these somatoform disorders. Well, biopsychosocially speaking, we know that psychologically the disorder has to do with what one focuses on to the exclusion of conflicting information. So they ignore any facts that might go against this perception. Social values of personal attractiveness can also be an issue. And if you have a tendency towards perfectionism and rumination, then you tend to possibly develop one of these disorders. Okay? Moving on, we're going to talk about dissociative disorders. Dissociative disorders are a splitting of mental processes like your thoughts, emotions, identity, memory, or consciousness. Dissociative amnesia is one type of disorder in which you are suddenly unable to recall important personal information, and it's not due to a biological reason. So, with this one, we're talking about someone that gets so stressed out about their situation that that old defense mechanism of repression kicks in. But this time, it kicks in so powerfully that you forget everything. You can't be stressed out about your life if you don't know what your life is anymore. Dissociative amnesia has an interesting cousin known as dissociative fugue. This is where, in addition to having no memory of your previous life, you just abruptly get up, you leave home or your job, and you travel to somewhere else, another state, another country even, and you start a new life with no memory of your previous life. It sounds like something off of a Lifetime movie, but we have seen multiple documented cases of this. Dissociative identity disorder is another dissociative disorder. It's one of the most famous psychological disorders out there. It used to be known as multiple personality disorder. So this is when someone has two or more identities, each with distinct traits that occupy the same person. So this person might have one personality that could be a gruff 30-year-old lesbian, and another personality that is a 10-year-old boy, and another personality that is a 50-year-old black man, and another personality that is a white supremacist. So these personalities can be anything, and they're usually developed as a coping mechanism. So biopsychosocially speaking, we know that you might learn to develop some of these disorders, like the fugue or things like that, as a way to help keep disturbing ideas out of your own mind. But biologically, we know, especially with dissociative identity disorder, that trauma is related to association. So in most cases of DID, or dissociative identity disorder, they start because the individual was horribly sexually abused at a very young age. We have seen cases where someone was abused as early as 6 months old by their father and by other men. And this woman would later go on to develop over 200 personalities. And what happens is the trauma is so horrible and you are so young that your mind doesn't understand how to help you cope with it. It doesn't know how to handle the awful abuse that is happening to you. So the only way it knows to protect you is to have you disappear for a while and let another personality come along and take the abuse. And then you now have this new coping mechanism of whenever you have to deal with life stressors, you now cope with those issues by creating someone else to go through with them instead of you. So it can be very dangerous. For most people with multiple personalities, which they call their alters, they tend to not be conscious while an alter is in control of them. And so they might wake up in places that they don't remember. They might be with people that they don't remember being around, or be recognized by others that they don't know who these people are, or doing things that they don't know how to do normally. All sorts of scary things. Sometimes the alters will physically abuse themselves, so they might take a hot iron to their arm, or they might cut themselves, or bang themselves up and smash pots on their hands, any number of things. So this can be a very disturbing and very dangerous disorder, if not treated. The last group of disorders we're going to talk about for this lecture are personality disorders. Personality disorders are characterized by enduring patterns of behavior that are maladaptive and inflexible. They impair personal or social functioning and are a source of distress for the individual. Personality disorders are maladaptive traits, but the question becomes, are they really disorders, or are they just a normal way of life? Are they redundant with other disorders? So a lot of times someone might have paranoid personality disorder, but is that just redundant with another anxiety disorder? This debate is still ongoing. In fact, in the DSM, personality disorders are listed, but only for informational purposes. They are not considered actual diagnosis. And when we talk to insurance companies usually won't pay for a session if the only diagnosis is a personality disorder, because insurance companies don't consider them disorders. They consider them just regular, admittedly different or unusual, but regular all the same, variations of normal human behavior. One kind of personality disorder that might disagree with that is antisocial personality disorder. It is when one has a pathological disregard for others, possibly due to having an unresponsive nervous system. They tend to be more impulsive and more prone to anger, and have an insecure attachment to their caregiver. Antisocial personality disorder is the personality disorder that most serial killers have and most hardcore prison inmates develop. Personality disorders are characterized by inflexible and enduring behavior patterns that impair social functioning. They're usually without anxiety, depression, or delusions, so they don't have any psychotic symptoms. They just are a way of life that can be quite troublesome. Here are just a few types of personality disorders. There's paranoid personality disorder, where you interpret others' behavior as threatening or demeaning, so you always think that people are talking about you or that people are against you. There's schizotypal personality disorder, where you have peculiar thoughts, perception, or behavior. I call it engaging in magical thinking. So you think that you're special, but you don't really have a reason to prove that you're a special person. There's schizoid personality disorder, where you have an indifference to relationships and flat emotional response. We had one client who was diagnosed as a schizoid, and he just didn't see the point in relationships or emotions, which was weird because he was married. And one day, he left work, and immediately after leaving work, he went on a fishing trip, and he was gone the entire weekend. And he had a great time. He enjoyed himself. But when he came home, his wife was understandably furious because he'd been gone the entire weekend, never told her he was going anywhere, never told her what he was doing, never called in or checked in with her, and she just couldn't understand how he could just leave her like that. And it's because he didn't see a point in telling her. He didn't see how it mattered. Borderline personality disorder is very interesting. It is instability in relationships, self-image, and mood. So when we're talking about someone that says that, oh, I'm so bipolar, I jump from one emotion to the next, they're probably not bipolar. They're probably borderline. This is someone that really will jump from being happy to sad to angry to jealous, all in the span of 5 minutes even. They are highly impulsive and are usually the kind of people that we will see most often in therapy. These are people that will need a lot of support because they are dealing with such strong, powerful emotions. They never just dip their toes and feel a little sad. It's always, I feel incredibly sad, followed by incredibly happy, then incredibly angry, and on and on. Antisocial personality disorder, as we mentioned before, is someone that persistently violates the law or other social norms and shows no guilt or remorse and is largely undeterred by punishment. So they don't feel bad about hurting other people. They don't feel bad about manipulating people or doing something that might, be a serious issue for someone else. Your feelings don't matter to them. We also will call antisocial personality disorder individuals psychopaths or sociopaths. The only difference between the two is while a sociopath is someone that doesn't care about social norms and doesn't care about other people's feelings, a psychopath also has psychopathic tendencies. So They might be more willing to kill someone or something like that. But you can also be a very well-functioning adult and have antisocial personality disorder. For example, the number one job, the number one occupation for antisocial personality disorder individuals, for psychopaths, mind you, is a CEO of a major company. In fact, all the top 10 occupations were things like members of the clergy, radio and TV anchormen, things like that. Anything that has a sense of power, professors even, anything that has power, and a psychopath or a sociopath is going to be drawn towards. The next one is avoidant personality disorder. This is someone that avoids relationships for fear of rejection. They just assume everyone is going to reject them, and so they will purposely sabotage any friendships or other relationships that they might have so that they can be alone because they just know that one day it's going to end poorly for them. So how do these personalities develop? Well, biologically, there are some genetic factors. We know that personality traits can be inherited, that antisocial personality disorder issues have less gray matter in their prefrontal cortex. But for the large part, most personality disorders are learned behaviors, and there's not really anything that we can do to unlearn this behavior because it has been ingrained as a part of who they are for many, many years. Psychologically, like I just said, we know that there is a learning theory. They might have taken certain childhood experiences and learned from those experiences and then shaped the rest of their behavior for the rest of their lives around that experience. They might also have misinterpreted other people's behaviors and then ran with it. Socioculturally speaking, we know that, for example, borderline personality individuals may reflect the fragmented society in which we live. So borderline people love to keep things at 100. They love to try and keep themselves as the same person while also trying to fulfill different roles in different groups. And because you can't do that, you can't be the exact same person with every person around you, it tends to get them in trouble. This is part of the impulsivity that they have. And that is it for psychological disorders. Please make sure that you are completing all of your assignments by the due date, and I will see you next time for the next assignment and the next session. See you guys then.